Hello, my name is Martin Brundle, and I'm the chairman of the trustees of the Grand Prix Trust. Now, as you might imagine, we've been especially busy during the pandemic, helping people out financially where appropriate, or otherwise advising and signposting on medical and other issues where we think there's other expertise around to help people out with whatever problems they find themselves in. We've also recognised at Grand Prix Trust that social interaction is absolutely key, especially in the last year. We've had some Zoom dial-ins, and we hope to re-establish our biannual reunion lunch and our regional meetings as soon as possible. We also produce leaflets and generally try to give as much advice and help as we think appropriate. Then hence our first webinar, and welcome to the Miracle Cure. So we're going to hear about how exercise might well help out with some of our everyday ailments instead of taking more pills. And I'd like to thank Dr. Philip Batty from the Schoen Clinic and our very own trustee, Mr. Peter Hamlin, also from Schoen Clinic, for giving up their time and expertise to give us this advice. Thank you for joining, thank you for your support, and I hope you find the webinar useful.
So Simon Sinek wrote a very good book in terms of leadership called Start With Why, and he describes the golden circle. So really this evening, I am going to focus on the why. There are specifics in how, and I'll touch a little bit on that. And then it's for individuals really to choose what they want to do in order to sort of maximize their health, because people are different, and people have got different interests, people have got different bodies, and so that needs a little bit of individualization, which is impossible on a talk to several people. But I'm really going to focus 90% of this talk on why, because I think we have lost sense of why. The title of my talk really came from this document, which was published in, 6 years ago now. Now, you may not know who the Academy of Medical Royal Colleges are. They are an august body. They are the sort of body that oversees all the medical royal colleges, be that surgeons, be that physicians, be that psychiatrists, or whatever the medical speciality, and there are numbers, there are tens of medical specialties. So they oversee, and they are the overarching body for all of them. And they published this document. And so I've plagiarized the word miracle from this document, albeit that there are many claims for many spurious treatments that everything's miraculous. Wouldn't it be great if everything were so? But we'll talk into this, because the problem is we have become more and more inactive over the years with evolution. And I think, I see more and more people using stairs on underground stations, but they're obviously a lot quieter now. But people's choices, we are inherently lazy, and we prefer to get our online groceries than walk around a supermarket. And I must confess, my wife once bought one of these, which is an electronic pepper grinder, that made me think, good grief, if we're not even going to be doing this to grind some pepper, then we are becoming lazier and lazier. So there is an inherent laziness about the human condition. Now, we are hopefully coming to the end of a pandemic, and there is no doubt that COVID has been the largest cause of deaths for some months in this country, but latest statistics show that it is not the greatest cause of death. So things are returning to normal, because by far the greatest number of deaths, even throughout the COVID pandemic as an accumulation, by far the greater number of deaths will be due to non-communicable diseases, NCDs, so non-infectious diseases. And if we look at the latest statistics from the World Health Organization, in 2018, non-communicable diseases killed 71% of people worldwide. So it's a huge cause of deaths. non-communicable diseases are cardiovascular disease, cancers, respiratory disease, diabetes, and a number of other conditions that can occur. So 71% of people worldwide, and there are 4 groups that can occur. Cardiovascular diseases, as I said, cancers, chronic lung diseases, and diabetes. So you may be wondering, what has exercise got to do with that and those main figures? Well, bear with me. In the UK, actually, the currently non-communicable diseases account for 89% of all people just prior to COVID, and it will return to this figure almost certainly, with 83% being related to the big 4 of cardiovascular disease, cancers, chronic lung diseases, and diabetes. Those are the big 4 killers in the UK. So if we're looking for a sort of miracle treatment, the treatment that every doctor and physiotherapist or every medical person, in my view, should prescribe to every patient every day is a treatment that prevents these non-communicable diseases and also treats the cause of those non-communicable diseases by reducing the risk factors. And there are a number of deadly sins of non-communicable diseases. There are 4 predominantly daily choices, lifestyle issues, tobacco, alcohol, unhealthy diets, and physical inactivity. There are 4 more metabolic issues, physiological risk factors, raised blood pressure, obesity, being overweight, high blood sugar, and certain blood fats. And then there is a 9th, psychosocial stress, which I will just touch on shortly later. So these are the big killers that cause a deadly web of chronic disease factors. What we need to therefore consider is the risk factors for multiple non-communicable diseases and the risk of dying. And this was a big study that was published in 2015, looking at 230,000 adults over the age of 45. And this looks at the relative risk of dying from any cause. And basically, if you've got no risk of dying, risk factors, your risk of dying will be 1 on a relative risk. And so we will see that for 0 risk factors, there is the relative risk is 1, and then for 1 risk factor, it goes up to 1.27. And as we accumulate these risk factors that might be diabetes and high blood pressure and cholesterol, as we accumulate these risk factors that I've referred to before, the relative risk of dying, particularly if you've got 6 risk factors, is significant. It's 5 times or more. So, the important thing that we need to do and need to be doing is identifying the risk factors for adults and treating them. Because this can reduce the risk of dying early by 5-fold, and those are significant numbers. So, but what if I'm too, if I feel I'm too old, I'm over 65, it really won't make a difference. What's the point? So if we look at the numbers for the age range of 65 to 79 and the relative risk of dying earlier from any cause, then frankly, it goes up significantly more. So it still applies to this rule of the cumulative risk factors in terms of increasing risk of death. And in fact, if we identify and treat the risk factors for those over the age of 65, it's even more important because you can reduce the risk of dying earlier by 6-fold as opposed to being 5-fold under the age of 65. So nobody is really too old to be considering of these issues. But okay, what if I've already got heart disease, blood vessel disease, or metabolic issues? It's too late, isn't it? It must be too late. Well, actually, if we look at that again with multiple risk factors in terms of those with already established disease, we can see that the sickest patients, i.e. with non-communicable diseases, they need the risk factor reduction the most. reducing the risk of dying early by 7-fold. So these are the people that actually need the risk reduction factors the most in order to reduce the risk of premature death. So, as I said, this is the web, the deadly web of chronic disease. And it becomes complicated. So what? If I can only treat one risk factor for non-communicable diseases in my patients, which one should I tackle first? Is a question that I often put to colleagues and doctors. Which one should I tackle first? Well, let's take a look at that. So which of these non-communicable diseases risk factors is the most important? So this was a study by Stephen Blair looking at males in the USA. And we can see the attributable risk factor for all-cause deaths in males. So we can see the risk of obesity, the risk of high cholesterol, the risk of diabetes, similar to high cholesterol, the risk of smoking and the effect that that has on risk factors for death. And this condition called smoker diabetes, which is effectively the combination of smoking, diabetes, and obesity. Obviously, that significantly increases the attributable risk factor, as does high blood pressure. But if we look at low fitness, that overcomes all of them. That is the biggest single factor in terms of the risk factor. The biggest risk factor is low fitness. That's in males. It also, and possibly even more, applies to females from this study. The significant effect of low fitness, low physical fitness, in terms of risk factors for death. Again, if we transfer that to an Australian population, again, big numbers, 231,000, as I said, the risk of dying from all causes in people over the age of 45. This came out from the study. So again, the risk factor, if there's no risk factors, your risk is 1, and then it accumulates related to that. So there's an effect of diet, alcohol, too little sleep, too much sleep. We're looking at this. Smoking significantly increases it. But this issue of smoke, physical inactivity, and prolonged sitting from both sexes over the age of 45 significantly outweighs all these other factors. If we look then we say, well, it's okay, but I'm asking patients to get physically more active and physically fit. But if we look at studies that have been undertaken comparing increasing physical activity against various pharmacological agents for various conditions, and this was a study published in 2016, if we compare all-cause mortality in terms of the effect of statins that many of you are probably taking, which is very commonly prescribed, we can see that physical activity and getting physically fit completely decreases the risk of all-cause mortality significantly more than statins. If we look at specifically cardiovascular mortality and compare statins that are clearly more effective in this specific group, so this has greater effect than all-cause mortality in this select population. If we compare it with physical activity, we can see that physical activity still outperforms statins. And there are a number of studies that have suggested that for any cardiovascular drug, it is estimated that physical fitness and physical activity is 7 to 8 times more effective than any individual cardiovascular drug. Again, if we look at one of the other big killers and we look at the effect of a mainstream medication to prevent the progression of pre-diabetes to diabetes, and the drug that's commonly used there is metformin, we can see that that will reduce the progression of pre-diabetes to diabetes by 31%, but physical activity still outstrips that of being 58%. So all these drugs are effective, but all will have potential side effects. And physical activity, yes, I'll come on to some of the side effects later, but is a very, very suitable and evidence-based alternative or supplement to mainstream medication. So, I often say that the drug or the treatment that every doctor in the UK, that every doctor should prescribe to every patient they see is regular physical activity. And I'll be a little bit more specific about that as we move forwards. So if we look at how many males in the UK do not take this drug in terms of physical activity, and we look at the sort of situation at the UK, well, it's basically 30 to 40% of males over the age of 18 don't do this, which is the third highest in the world. So we're pretty poor. If we look at females, the numbers are even greater, 40 to 50%. So we are the second highest in the world for females in this category. Which really beggars belief in terms of the effect that this is going to have on the nation's health. Again, this is WHO Global Status Report on Non-Communicable Diseases, and if we can look at the amount of people that are not taking physical activity in the UK, we can see that outstrips all the other major effects of healthcare situations that are occurring. So physical inactivity is the most common risk factor for non-communicable diseases in the UK and in the vast majority of the world. So, how is regular physical activity beneficial to your health? So, what does it do? Well, the health benefits of exercise have been known for a very long time, even before the onset of scientific research. And Plato, back before Christ, said, lack of activity destroys the good condition of every human being, while movement and methodical physical exercise save it and preserve it. So the great thinkers of our times, our ancestors, were aware of this before the science continued to prove it. So let's look at this then. So if we're talking of regular weekly physical activity and reducing the risk of dying, how much activity do we need per week over the age of 40? So this again was a study that was published in 2012. So basically, if you are walking slowly, so a MET is really the equivalent, 1 MET is the equivalent of basically a resting metabolic rate. So if you are sat in a chair for an hour, it's equivalent to 1 MET. So if you walk slowly for 60 minutes, it has a significant effect. It's not asking a great deal, but that will reduce your risk of dying by around 19%. Climbing stairs 10 minutes a day, again, that increases the intensity, and that will reduce it even further. If you start to get a little bit more out of breath, a little bit more sweaty, and you do some strenuous hiking for 2 hours a week, that will reduce your risk further. Cycling and working a little bit harder, again, a greater effect. So you can see that with the progression of exercise and the progression of physical activity and the demands of the physical activity, that this has a significant risk reduction in dying after the age of 40. And, there are multiple additional benefits of regular physical activity. And this is from the NHS website. As I've said before, those that take regular physical activity have got a significantly lower risk of early death. Probably most of you will be aware of the lower risk of coronary artery disease and stroke. There's a 50% lower risk of type 2 diabetes. Now, many of you won't be aware of this, but there are 7 cancers that are proven to be at lower risk in those that are physically active. And there are studies that have shown there is a 50% lower risk of colon cancer, Some studies have said 30% lower risk of breast cancer. There was a study published a couple of years ago that demonstrated there was a 60% reduction of lung cancer, And again, it's counterintuitive in some way. People say, oh no, you should rest, you shouldn't do too much exercise because you'll wear your joints out. That is actually not really the case. That's not proven. And actually, this is the NHS website. It says there is an 83% lower risk of osteoarthritis in those that take regular physical activity. As we get older, there's a much lower risk of hip fracture, which is contributed by a significant reduction in the risk of falls, particularly in the elderly. And in terms of cognitive function, there's a 30% lower risk of depression in people that take regular physical activity, and also significantly reduced lower risk of dementia in those that are more physically more active. These are big numbers and obviously big health issues that affect significant numbers of the population. So, what dose should we do? What should we prescribe? Well, there are a number of guidance that are out, but the international guidelines for what, and basically people in my specialty will be more specific and prescribe various things, but in general, there should be an exercise of greater than 30 minutes per session. It should occur on most days of the week. Intensity should be 60 to 8% of your maximum capacity, and a rough guide of that, of what your maximum heart rate is, 220 minus your age. And there are really simple electronic devices now that can give you feedback on your pulse. You should just be able to hold a conversation, maybe a little breathless between sentences, and you may rate your perceived level of exertion. There should be a degree of endurance, walking, brisk walking, jogging, cycling, swimming. On most days of the week, there should be this type of exercise. And these are the main issues that are important for preventing the big stuff I was talking about in terms of heart disease, in terms of strokes, in terms of cancer, and depression and dementia. But we also need to do some muscle strength and probably balance work more than flexibility, 2 to 3 times per week. And we often don't do that. Strength is really important. You don't need to be a gym buddy or something of that nature, but we do need to be able to support our skeleton. We need to look after our skeleton, and strength is important to look after your joints, your back, your spine, your hips, your knees. Those load-bearing joints need some muscle strength to take a little bit of heat off them. And where weakness and muscle weakness occurs, you will be putting more force through the joints, and as such, you will be more at risk of developing joint problems and joint pain. So, in summary, 150 minutes of moderate to high intensity endurance physical activity per week, with strength and balancing 2 to 3 times per week. And there are various guidance that come in. Sweating is very healthy, and that's a good indicator that you are working. Obviously, there are some rarely arbitrary issues regarding the number of steps, but the more steps you take, that is healthy. And using stairs as an option rather than the lift. And I'm pleased to say that I met Peter Hamlin in the clinic earlier, and he was avoiding the lift and climbing the stairs. So it was very helpful to see that he was doing that today. Sleep is important, and really sitting less. Sitting is really not a healthy issue for long periods of time. So, those people that are working from home and those people that are sat for long periods of time, just stand up occasionally, a few times an hour. Maybe just walk around your chair or just get moving. Muscles are lazy, and basically, if you don't use them, you will lose them. They switch off, and they need to be sort of worked a little bit, really. So if we look at the Chief Medical Officer's physical activity guidelines, and Everybody knows who the chief medical officer is now. No, nobody would have known probably 15 months ago. But they've said in terms of the scientific evidence, there is moderate or strong evidence for children bone health, cognitive function, cardiovascular fitness. These are all important issues, particularly depression. So there is moderate or strong evidence here in the scientific literature. In adults, we've spoken about all-cause mortality, stroke, hypertension, 8 cancers it mentions there: depression, cognitive function, dementia, improved sleep. Big health issues that are best avoided. And in the elderly, in terms of reducing the risk of falls, frailty, and physical function. One of the things I say to my elderly patients is you are never too old to get stronger or fitter. And where that is a really important message for functionality and independent living in old age. Because as we get older, we get weaker. This is a process that we call sarcopenia. And again, this is a slide from the Chief Medical Officer's physical activity guidelines. And if we look at strength and balance here, and then we basically look at our early years, working age, and later life, we're born weak as a kitten, and then gradually we get up on our feet and we are more capable. And then we get stronger and stronger and stronger. And we reach our peak in our early to mid 20s of potential strength. That is the greatest peak, unless you are sort of doing some regular, really heavy strength training as an athlete. But generally for the population, this is the peak of your potential strength. So what I'm constantly doing is trying to keep people away from the blue, because as attrition occurs and as we lose probably about 8% of our muscle mass every decade, as that creeps on, we can reach a capability threshold here where independent living and frailty and falls is more likely. So I'm constantly with my patients trying to push them a little bit more to the green to try and delay this onset so that people can live longer, healthier lives, because that really is where we all want to be in our old age. Now, again, I make no apology. These are the most recent physical activity guidelines, and you can look them up on the web for different age groups. There are guidance for early years, birth to 5. This is the mainstream of where most of us will be. And again, I've mentioned about the 150 minutes, building strength on at least 2 days a week, and how it reduces the risk of cancers. Yeah, but make a start today. It's never too late. Some is good, more is better. Every minute counts. These are important messages for the vast majority of the population. There are physical activity guidance for disabled adults, again, for their health and to try and improve their independence as well. Physical activity guidance for pregnant women, again, with the specific needs of pregnant women. And you can see still advising muscle strengthening activity, keep active, keep going, and it prevents and reduces the risk of many of the side effects that can occur. Obviously, there are specific guidance on that. And I guess, if I come to some of, inevitably, exercise can cause some injuries, and that is a side effect. They're usually very minor and more of a nuisance, but they can spoil people's motivation to exercise. So obviously, if you're already injured, get some advice. You may need some specific expert help. Start slowly and progress gradually. Do a little bit of a warm-up and some stretching, and do some balanced stuff to be sure that you're, that might just be standing on one leg while you brush your teeth, alternating that, doing some simple things of that nature to just keep your balance ticked over. Use the right stuff, the right shoes. If you're going to play some sports, use the right equipment. It's really important, if you're going to do some strength-based exercise, that you've got the right technique. Exercise is really, really very safe, but where people's technique is poor, or they start to go out of control, as I would say, and they're not controlling the movement because they're not strong enough, then that's important. Occasionally, some people need to use some strapping or bracing. Make sure you eat right. And as I say, psychological status is linked to injury risk. If you are down and fed up, you are more likely to become a little bit injured, and consider other lifestyle habits. You will be aware that there are various events, Great North Run, London marathons, that are very well marshaled, but occasionally tragedies occur and sudden death occurs. In mass events, it is helpful to have a sort of screening process, and I just show this because with screening for races, so endurance events, the risk of serious life-threatening complications with relatively simple, straightforward screening under the supervision of a sport and exercise medicine physician, but with questionnaires leading to some people having physical exams, a small proportion of them, you can significantly reduce the risk of life-threatening medical complications. So where there are issues and mass events, they can be much more reduced. So, as I say, the treatment that we should all, as medical practitioners, and that I would advocate you all to do, and I hope I've explained the why that I was talking about, is related to physical activity of length. So you can see here the benefits on this curve from a study versus the risks and harms. And basically, the benefits, even for little stuff, increase significantly. And as you go and you progress to exercise for fitness, you will get the maximum benefit, moderate to vigorous activity. If you are training for sport, however, and if you are really pushing your body, there is a greater risk of injury, and this can tend to taper, and the risks for training for sport in terms of pushing your body to the limit can result in more musculoskeletal issues. So if you want to get the most bang for your buck and least risk of injury, this is the sort of area that is the healthiest and lowest risk area. So fast walking, a little bit of jogging, those are the areas where you will get maximum bang for your buck and for your exercise kick, or the equivalent to jogging if you hate running or you can't run for various different reasons. I guess the other thing that has come about is the use of exercise now in terms of various medical conditions. And in the summary, I alluded to the recent NICE guidance. And NICE are the organisation that is an acronym for National Institute of Clinical Excellence. There are various other people that might play on that acronym, but nonetheless, if we look at this pathway now that has just been published, and there are one or two other areas of NICE guidance where this is coming in, and this is evidence-based, even for chronic pain, using the NICE guidance, obviously there needs to be assessment, there needs to be some recommendation, but basically for those issues, management options are in an exercise program and physical activity, maybe supported with some psychological therapy, but pharmacological management too. And one of the problems we now face because of various issues is we've got a lot, masses of people that are now being prescribed lots of drugs for chronic pain, some of which are more or less effective, some of which frankly don't appear to be very effective at all, but can create dependency. So the evidence is becoming stronger and stronger that we should be using lots of exercise programs and physical activity for treating people with these long-term distressing, painful conditions, albeit that they may not be particularly life-threatening. I mentioned that before the scientific process was developed and randomized trials, that people were aware of the benefits of exercise. And as we've become more scientific, we seem to have taken our eyes off the wonders of exercise and what it can do. I'm pleased that the science is now looking at exercise and the effectiveness much more. But this is a quote from Edward Stanley, who's a former British Prime Minister in 1873. But even in 1873, we think we're time pressured now. I think there were time pressures even back then. And maybe the time pressures is more an excuse than a reason in some ways. But those that think they have no time for exercise will sooner or later have to find time for illness, which was said in 1873. So thanks very much for listening. I will stop sharing my slides now. I see some questions have come through, and I will hand over to you, Peter, to collate the questions.
I think it's worthwhile, just before we get into the questions, explaining a bit about who you've just listened to. Phil qualified in 1987 from Liverpool University, and his sports CV is quite extraordinary. Manchester United Football Club, Blackburn Rovers, Manchester City Football Club, the English Institute of Sport, Sedbergh School, Middlesex County Cricket, England Rugby, the English National Ballet. He's a training director in sport and exercise medicine and the educational lead for the Independent Doctors Federation. That is quite a spectacular breadth of sports and exercise expertise. And he once said to me that with a name like Batty, he was never going to become a psychiatrist. And but he has got into everybody's head. And what he's got into everybody's head is really two things. One is that exercise is important. And the other is this slightly schizophrenic life of this new breed of doctors, the sport and exercise physicians, who really developed in the UK out of our Olympics in 2012, that they deal not only with the injuries associated with exercise and sport, but the benefits of exercise and sport. And hearing the benefits of exercise and sport so clearly enunciated is, every time I hear it, inspiring. It seems to me, Phil, that you had really three very simple messages there. First, the best way to hold on to your health is by exercising. Second, the sicker and older you are, the more important it is that you keep exercising. And third, there is no drug. There is nothing you can get from your doctor that beats your own exercise. You are the strongest, best physician you know. And any individual can believe that themselves. So thank you for that amazing tour de force. We have had a few questions come in. Perhaps the first one would be to do with the link between obesity and fitness. And this comes from Olivia Carter, who asks, why are obesity and lack of exercise separate measures in some of these figures? Do these two not overlap to some degree?
It's a good point. And it's somewhat controversial because there was, you'll have seen it probably in the regular press, there's a debate about whether being fat is worse than being fit. So this element of, are you better being thin and unfit or fat and fit? And there are some people that are overweight, but they're actually, from a cardiovascular viewpoint, really quite fit. They can run around, they can do lots of exercise, but they are overweight. And there are conflicting studies as to which is the most important. Previous studies have, Stephen Blair's done a lot of it, and Stephen Blair is a researcher from the States who is overweight, and but he's fit, and he's justified, whether it's cognitive dissonance or not, he justifies it by the research that he's done that shows various issues that you are better being fat and fit than thin and unfit. There has been more recent research that's turned that around a little bit. So I'm just going to play neutral on that. But it is, it is important. There are many people that are thin and think that they are fine because they're not overweight. Diet's an important and interesting point, and again controversial, because should we years ago lots of research was done based on an American president having a coronary in the 50s, and the sort of low-fat diet procedure was sort of introduced in the late 70s worldwide on that, on a low-fat diet. Now, what's happened is that we've replaced that largely with carbohydrate, because you've got to eat something. So carbohydrates is quite cheap. And then if you look at the figures from that, it appears that from that advice, that the rates of obesity have shot through the roof on that low-fat diet. So there's a lot of controversy about whether it should be low-fat, or otherwise. But there's no doubt that for many people, exercise will overcome many things. It's not, in terms of being overweight, I tend to tell people that being overweight is largely dietary focused. I think being overweight is about 80% diet and about 20% exercise. And there is a saying that you can't, in terms of weight, you can't run off a bad diet. It will reduce other risk factors, but in terms of the singular issue of being overweight, it will help a diet, but it won't. You can't lose vast amounts of weight by just exercise.
I suppose to summarise the answer to that question, there's a huge overlap between obesity and inactivity. But if you dissect out the two factors, they're both independently bad.
Yeah.
It's also difficult to keep exercising if you're very overweight.
It is. There are different ways of doing it. They are both independently bad, but they are accumulative as well. So it's a 1 + 1 = 3 rather than 1 + 1 = 2, if that makes sense. So they're both independently bad but accumulative. So that's clear for sure. But it is hard. There are things, and I deal with, and certainly, frankly, if you look at the evidence, if your BMI is over 40, then frankly, you are in serious, dangerous health issues. And the effectiveness of dietary measures, drugs, and exercise, if you look at the evidence, is really poor. And those are the people where really we should be considering, probably on the evidence, bariatric surgery.
Bariatric surgery, for the audience, is the surgery that's aimed at reducing your weight, so clipping your stomach, intestinal bypass surgery. So we've had a couple of questions around the same issue, one from Richard Wise, another from Arlene Banson, about whether you should insert breaks in your exercise regime. So Richard cycles road and mountain biking every day. Should he have rest days? And Arlene was wondering if she'd be better doing intermittent, intense exercise some days of the week, or moderate exercise every day of the week.
I don't think, well, I think some of it will depend on time. So if you're doing intermittent high intensity, you probably can reduce your 150 minutes to 75 minutes if you're doing it that way. Personally, I hate it. It hurts and I don't enjoy it. So I'm not going to do it. So I think that's not something I like to do. So I like to just go out and plod and jog or cycle or do something of that nature. If you enjoy high intensity exercise, go for it. I think there is a slightly higher risk of musculoskeletal injury from those activities. That can occur. And sometimes with the HIIT regime stuff, people's form goes. So, they start moving in an incorrect way, and that can precipitate some injuries in some ways. So yes, you can do it if you're time pressured, and that's certainly better than nothing. But, I think the evidence in terms of, the regular plod, the regular sort of 30 minutes steady state, or the HIIT stuff, it's marginal. where there's a benefit. The most important thing from an individual perspective is that you'll do it. And to do something, you've got to reasonably enjoy it, or certainly not hate it, if that's the case.
Okay, we've had a couple of questions in then. They're talking about exercising when you've already got something wrong with you. So we've had a couple of people asking us about exercise when they've either had spinal surgery, a bad back, one with coxodynia, and a few other inquiries about other joint-related issues like exercising with hip problems, knee problems. Just run us through how you would think about tailoring your exercise to the common maladies.
Well, you know, I think that people should live their lives as they want to live their lives. So what I quite like is when a patient comes to see me and says, I want to do this, this, and this, but I can't because I'm in pain, blah, 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 blah. People tell me I can't do it or what have you. But so working with somebody to do it. So first of all, you know, I don't think that anything's in, you know, there are very few things in life that are impossible. If you want to do something, people do amazing things in amazing situations with amazing disabilities all the time. And, you know, I'm sort of humble to the human body, but the principles are that you need to get some strength around whatever is hurting you to take some heat off that joint. Now, if you are, even with the simplest of exercise, which is basically what we call an isometric contraction, so where you are basically holding that joint still, but contracting it and contracting the muscle. So that starts off by just switching things off to an isometric. So you're just holding and tensing the muscle without moving anything. And then you will progress it to some range of motion exercises. So, you know, I will work on things that people can do. Focus on the exercises you can do reasonably pain-free. I do think some pain where people have already got pain, I don't think pain will immediately go. And so I tend to say to people, you will be working within a pain range of probably 1 to 3, 1 to 4 out of 10. If people are in too much pain to do exercise, they may need an intervention. That might involve some medication, some drugs. That might involve an injection to just give a short window of period for people to do the exercises. But it will start with strength, and then I will progress things to partial body weight strength. I'll then progress things to various bits of elastic that people can do at home, and a whole variety of exercises, working with physiotherapists who are really good at this sort of thing, to sort of help progress it. But start slow and don't give up and keep going. And gradually you will, most people will get stronger. You are never too old or never too injured to get fitter or stronger, unless, you know, if the nerve is intact, there is no reason why we can't get you stronger or that muscle group stronger.
Well, I've got a couple of other great questions. One is from Peter Burns. Why do you think there is such a reluctance in the medical profession to promote exercise? I have Parkinson's, and the mantra amongst our clinic is that exercise is key, but this does not seem to be widely promoted. A team of 12 Parkinson-affected people are swimming the Solent to raise awareness and to generate funds. So why do you think it's taken so long for this to be recognized, and why do you think our colleagues aren't promoting it more than they should?
Well, that's outstanding, you know, to be swimming the Solent. That's fantastic. As I say, people do all sorts of incredible things with incredible medical conditions. So I applaud you. I think it comes down to education, and this is something that I've tried to implement. It comes down to medical education and what we're taught in medical school. Because frankly, my son's graduated 2.5 years ago, and compared to that. So you're at medical school for 5 years, and effectively you are taught three things, three ways of managing things. You are taught to prescribe drugs, you are taught to operate, and you are taught some talking therapies. And basically, the whole of the medical management where we're treating people is down to those three issues. That is what you're taught. We're not really taught much on nutrition, which is a big issue as well. So my son was 5 years at medical school, and he had one lecture in 5 years on exercise. One lecture in 5 years. I lecture to the medical students at Lancaster University. They get one lecture in their first year. I've got 1 hour to try and make an impact and to try and get some resonance in them on something that they rarely get examined on as well. So they just want to, at that stage, you just want to pass your exams and you just want to get through the next hurdle and the next hurdle. So frankly, if you've got three tools, if all you've got is a hammer, then everything you see is a nail. So I think it's lack of education. I think it's people feeling, I think it's people afraid that, they'll tell somebody to do some exercise and they'll get hurt or they'll die, and the risks of that are much less than the risk of prescribing drugs or operations. So, frankly, it's due to education and sadly ignorance, and that is part of my goal and my mission of giving the talks that I've sort of given this evening.
I think that's absolutely right. I would have answered it in just the same way. It's there is an entire industry of medicine that keeps us doing the same things we've always done, and to change a juggernaut to think of a fourth tool, exercise, is takes a lot of time.
I think it is difficult, but and one of the worst things that I think I would hate to do, and it would be wrong to medicalize exercise. It's there for everybody to do. It's not a doctor's role in some ways to do that. But I sort of see it as a sort of pyramid. So the vast majority of people at the bottom of the pyramid should just be doing their own thing and exercising, looking at those guidance, and they don't need any medical advice at all. And as you said before, those are people that are taking ownership of their own health, and they're taking it and they get it. There might be a little layer above that might need some help. That might just be they get stiff and they might need some massage therapy. They might need a personal trainer. And there's another layer on top of that. And then there's another layer of people that might need some physiotherapy support intermittently. And then there's another area of the triangle, which is a significant number of people with medical conditions or much more complex musculoskeletal conditions, but there are a small minority that might need to see a doctor that knows something about exercise. But the vast majority shouldn't come anywhere near a doctor. And so, I think one of the things that disappoints me is that doctors don't engage more with the fitness industry to sort of delegate it and say, let's do this. There needs to be more exercise on prescription roles where doctors can just pass people on to qualified personal trainers, qualified people, instead of reaching for the prescription pad. That's where things really need to go.
Yeah, we are not alone in Britain in having a National Health Service in name. It's actually a National Sickness Service where we sort people out who've lost their health. And this prevention method is really important. On another time, we'll talk about how Formula One actually contributed to the development of sport and exercise medicine and this health industry, and it had a big role in that. So it behoves us to finish with questions from the Formula One world. I've had one from our leader, which I'll come to, and another from Olivia Carter. Olivia Carter is just taking up Formula Woman racing, which, if you don't know about this, Phil, is worthwhile having a look at. These are sports associated with high G and a need for great stamina. So perhaps you could answer her question, which is what exercise is good for her, whilst rolling into that, a question of one of the fastest men on the planet in his time, Martin Brundle's question, which is how important is stretching and physiotherapy for keeping folk working and exercising?
So my focus mostly is on strength. So I do think in terms of motorsport, and there's been great innovations in motorsport and people working in motorsport. So I do think you need to prepare yourself as best you can for those high G activities that you do. So issues like neck strength, what neck strength exercises are being done, what sort of core stuff is being done, those issues, so that you can control your head and control your movement under that extreme pressure, I think is an important health, but actually I think it's a really important performance issue in terms of motorsport. So being sure, and again, there are tools that can measure your strength, and there are issues, and so getting some numbers on it and some data on it is a useful thing to do. But I do think there's a very good focus to be had there. And also some explosive stuff. I'm just thinking of various situations about when you may have to sort of get out of a car quickly and things of those situations. So those are all important issues, I think, in terms of your strength focus. Now, in terms of physiotherapy, I think from a high performance perspective, I think physiotherapy is a very useful specialty, and I've used physiotherapists in all elite areas, both from an injury prevention perspective, an injury risk reduction perspective, but also to pick up some niggles. They might just detect a little something developing. Suddenly, a joint might not be moving the same way that it did before, etc. Why? What's happening? What's the underlying issue here? How should we address it? Personally, I'm not a huge fan of stretching. I think if we look at the health benefits of exercise, we know the health benefits of cardiorespiratory fitness, well documented. We know the health benefits of strength and movement in terms of looking after the skeleton, well documented. I think some degree of stretching makes people feel better. I think, but in terms of the health benefits of stretching, that's less evidence-based. And indeed, there are a group of people that are hypermobile and can move into all sorts of positions, and actually they tend to be at more risk of pain than the general population. So stretching within limits, so long as you're not putting your body in a crazy position and loading a joint in a crazy position, that's fine. But it's not something that I think I would spend lots and lots of time on personally.
Okay, well, I think that's perfect timing. We've just hit 8 o'clock. Thank you, Phil. That was an amazing tour de force and a really interesting session. And may I finally just close by thanking everybody who's helped organize this, and in particular Schön Klinik, who not only hosted Phil and myself this evening, but helped with all the technical aspects, and in particular Ed Collier, who has taught us all how to do this. So thank you, Ed. Thank you, Schön.
Thank you very much. Thanks.
And good night, everyone.
Thanks very much. Good evening, everyone.
Bye-bye.